Hi, Dr. Patricia Ford. I'm a hematologist oncologist, and today I'm going to talk about the management of iron deficiency in gastroenterology. So I want to start out by talking about how common this is. We're going to go through some of the causes of when to screen. So for any patient who's anemic, there may be some hints that you have iron deficiency. If the CBC shows that there's microcytosis or small cells, that'll show a low MCV. That many times will be iron deficiency or potentially thalassemia. But any person who's anemic should have iron studies done, and that'll include a ferritin and an iron saturation. And in general, if the ferritin's under 20, the iron saturation's under 30%, you've documented they have iron deficiency anemia. If this is occurring in a male or postmenopausal women, we have to look for GI sources of occult bleeding. So let's talk a little bit about how prevalent GI bleeding is and what are some causes. You can also have iron deficiency from malabsorption, and we'll discuss that also. So in 61% of patients who are iron deficient, you're going to find a GI source. In the elderly population over 65, 30% of them are going to have iron deficiency anemia. Let's just look at people with reflux. People with reflux are frequently on proton pump inhibitors, and in that population, 20% of chronic PPI users will have low iron levels and be iron deficient. In colorectal cancer, we'll find this about 20% of the time just as we're working up iron deficiency anemia. So kind of highlights the importance of doing our endoscopies. On our patients who have colorectal cancer, 50% of them are also iron deficient and need treatment. Common also is inflammatory bowel diseases. And inflammatory bowel diseases, you'll have iron deficiency both from GI blood loss and also from malabsorption. They may have had resections done, which will also contribute to the malabsorption. If the source is a lower GI bleed, common reasons are diverticular disease and hemorrhoids. In our patients who have undergone bariatric surgery, about 10 to 40% of them, due to malabsorption, will develop iron deficiency anemia. So this is a chronic and lifelong problem that we need to screen for, both iron and B12 deficiency. New is the use of GLP agonists for weight loss, and what we're finding, and this is a new category, is about 10 to 40% of those patients have low iron levels. So keep that in mind also as a risk factor. For our patients who are on aspirin and any antiplatelet agent or anticoagulant, just think about the fact that that also increases the risk of bleeding from some underlying things such as diverticular disease, colorectal cancers that may be undiscovered yet. So that is another risk factor. What's the impact of not treating iron deficiency anemia? Well, we all know the symptoms of iron deficiency, so just poor quality of life. By treating this, they'll have increased energy, more stamina, and less of the symptoms that we typically see. Also, we know in GI disorders, this will impact our healthcare costs. You can have longer stays in the hospital and other health costs associated with iron deficiency anemia. So how to treat? This is one of the disorders where we just find oral iron is ineffective. Number one, all of the side effects you typically see with oral iron will also exacerbate some of the GI disorders, especially inflammatory bowel disease. And they just won't absorb it because of the reason we've talked about. So it's poorly absorbed, exacerbates their side effects, and just does not work very quickly. So preferred will be parental iron. And you can use any of the iron preparations. They're all equally effective. Iron dextran has the advantage of total dosing, but any of the preparations would be appropriate. So in summary, GI causes are a prevalent and common reason for iron deficiency anemia. In adults, we need to increase our detection and early screening of these patients. And then of course, we want to treat this preferentially with parental iron.